Hi, this is Dr. Nick with the ECG Academy. We're going to go on with our discussion of AV node dysfunction, talking about second degree AV block. So we covered first degree already. Now we're going to do second degree, and you can see that the classification is a little bit complicated and that there are different types of second degree AV block. There's type 1, type 2, and there's actually high grade, which a lot of people don't think about. Okay, well, a quick review of the physiology of the AV node. Remember that the AV nodal cells fire because of calcium currents that go into the cells. And so the upstroke of the action potential is a little slurred compared with the His-Purkinje system, like the His bundle and the bundle branches, where the action potential is much sharper and there's a little bit more of a plateau phase. So these two types of cells behave differently. We'll talk more about this in the physiology section, but in the AV node, the cells basically will delay the signal as it passes that signal down towards the His bundle. And if the atrial rate is too fast, what will happen is the AV node will fail to pass the signals down. You'll get delaying of conduction and eventually failure of conduction. And this delay or failure of conduction results in prolongation of the time it takes for the signal to get through. So the PR gets longer. If the PR gets longer, it usually means there's delayed conduction within the AV node. On the other hand, the His-Purkinje system, being sodium dependent and having a very sharp upstroke, behaves more in an all or none fashion. In other words, those cells either conduct it or they don't. So what happens if you have failure of conduction below the AV node is that you'll have AV block without any prolongation in the PR. So the PR is constant in conditions that result in AV block below the AV node. And this physiological distinction between these two cells is responsible for different behaviors labeled as type 1 and type 2. And clinically, the level of the AV block makes a difference. This is something that we'll cover in more detail in one of the advanced talks on physiology. But for now, let me just clarify what type 1 and type 2 second degree AV block look like. Let's start with this example of an ECG. At first glance, when you look at the forest, you see the QRS complexes appear to be fairly regular. And if you've learned how to count up boxes, you'll find that it's going at about 50 beats per minute. In front of each QRS complex, there does appear to be a pretty clear P wave. And it's up in 1, it's up in AVF. So the rhythm is sinus bradycardia. And now let's take a look at the PR interval. The PR interval starts just before this heavy line, and the QRS complex starts right at this heavy line. So the PR interval here is a whopping 400 milliseconds, twice the upper limits of normal for a PR interval. And when you look across, you can see that the PR interval looks pretty fixed. Or does it? I don't know. I'm starting to get the sense that this is on this side of the center part, this is getting a little bit longer. And if you look at this one, it's even longer still. So somehow the AV node is starting to delay the signal. It's taking longer and longer to get down the AV node. And then what happens? Look at that. A P wave, but there's no QRS complex following that P wave. So this is an example of AV block. The atrium fired, but there's no conduction to the ventricles. So you have AV block now. Is it first, second, or third degree? Well, clearly it's not just first degree because one of the P waves failed to conduct. It's obviously not third degree or complete heart block because most of the P waves do seem to get through. So this is second degree AV block. Now, the fact that the PR is getting longer tells you that delay is most likely occurring in the AV node. And with prolongation of the PR interval, that allows you to make the diagnosis of type 1. With type 1, what happens is the PR gets longer and longer before the beat finally blocks. Let me give you a more typical example of type 1 second degree AV block. Okay, here's an example of type 1 second degree AV block. Remember, in type 1, the PR interval gets longer before a P wave fails to conduct. Now, where do you even start with this ECG? Well, I think it's important to first look at the forest, and what you see here are 2 beats, and then there's a little bit of a longer interval, and then you see 1, 2, 3 beats, and then a longer interval, and another 1, 2, 3 beats, and then a longer interval, and you're starting to wonder if there's a pattern here, a pattern of irregularity. Yes, it's irregular, but what you have is a group of QRS complexes, and then a pause, and then here's another group, and a pause, and here's another group, and a pause, and then it keeps on going. So this is actually known as group beating, and group beating is pretty characteristic of AV block. Now, if we just concentrate on one of these groups, let's start to pick this apart. We'll start to look at the trees. In front of this first QRS complex, you do see a P wave, and the PR interval looks to be a little bit on the long side, like maybe 210 or 220 milliseconds. So if you put a 220 there, and now let's see, are these P to P intervals regular? In other words, do we have just a sinus rhythm? Well, let's take the next P wave, and if you want to make it easier, you can take your calipers, bring them on down, and put them on top of the beginning of the P wave, resize them, and then if you march these calipers out, you can see that the P to P interval is really quite regular. Okay, so the P's are marching on through. The sinus node is firing at a regular rate, and if we try to figure out what rate that is, we put it on a heavy line and then count off 300, 150, 100, 75. So it's about 78 beats per minute. So we have a sinus rhythm at 78 beats per minute. But what's happening is the PR of the second beat is longer than the first beat. You can see it visually. And I think the best place to look at PR prolongation is at that PR segment. See that segment after the P wave finishes and before the QRS? Look, that segment is getting longer. And if you measure this PR interval, it comes out to be about 280 milliseconds. And now this PR segment is very long, and this PR interval is close to 400. It's like 360. Now what happens is this P wave occurs on time, because we've already mapped these out, and there's no QRS complex following it. So to kind of like shorthand it, we draw a little signal that looks like that, and that means that this P wave blocked. It did not get through the AV node, and it leaves you with a pause. Lo and behold, following that pause, the pause that refreshes, that is, the PR interval gets shorter again, and then it gets longer, and then you block again. And so we have a pattern here. There's a pattern of 4 P waves to every 3 QRS complexes. And this was first described by a guy named Wenckebach. And this Wenckebach periodicity would be expressed as 4 to 3. That's the ratio of the P waves compared to the QRS complexes. Now, in type 1 second degree AV block, there's always one more P wave than there are QRS complexes. So you can have 4 to 3, you can have 5 to 4, you can even have 3 to 2. There's always one more P wave than there are QRS complexes. Otherwise, it makes it a different type of second degree AV block. Okay, so now how do you make this diagnosis? You see group beating. You see P to P intervals that have to be regular. Remember, the sinus node is just beating at a regular rhythm. It's not that you have premature beats that encounter an AV node that's not quite ready to conduct. Remember, we saw a premature atrial beat that conducted with the first degree AV block in the last lesson. We'll see in the video on premature beats that you can get non-conducted premature beats because it basically catches the AV node with its pants down. But what we have here is a regular atrial rhythm, which is sinus rhythm, marching along at a regular rate. And what happens is the AV node delays the signal progressively, the PR gets longer, and then fails to conduct. Now, there's kind of a way that you can check to see if indeed you have classic Wenckebach, and that is the rule of the pause. The pause should always be less than 2 times the previous R to R interval. So if we take our calipers and move them on over and check this R to R interval, well, let's adjust those so that we get the R to R interval exactly. And then if we move those calipers over and see what's the size of this pause, we can note where the tip of the caliper falls here and then move it on over, and you can see, look at that. That if you take the previous R to R interval, that the size of the pause is always less than 2 times the previous R to R interval. So if you measure that over, it comes out to there. The pause is less than 2 times. And that's a rule that you should be able to prove if you want to make the diagnosis of type 1 second degree AV block. We used to refer to this as Mobitz 1, but I think that type 1 is a more generic term, and we should use type 1 and type 2 instead of Mobitz. In terms of AV node classification, we've now covered type 1 second-degree AV block, and you've recognized what it looks like. Let me show you another example. Okay, here's a rhythm strip that came off of a CCU, and when you first kind of glance at it, you're trying to figure out, well, what's going on? And what you should be able to see is a slight irregularity if you look at the whole forest. If you map out the QRS complexes, you see that this interval is a little bit longer than this one. And then it gets shorter again, and then it gets longer. So it's almost like you're alternating short, then long, then short, then long. So there is a bit of a pattern to it. It's a regular irregularity. When you see this, think group beating, because what you're talking about really is a group of two and a pause and then another group of two. Well, if there are two QRSs in this group, how many P waves should there be? Well, there's always one more P wave than there are QRSs. So let's see if we can prove 3 to 2. Well, where are the P waves? Look around, and you should be able to see that this is a P wave here. Now let's look for a signal that looks just like that, and you see it right there. It's kind of at the tail end of the T wave, but remember, compare this T wave with that T wave, and you can see the two are distinctly different. And remember what I told you about P waves being sharp and spiky compared to T waves. So you have this one here, and then you have this sharp spiky guy right on top of the T wave. Do these map out? Well, let's see. If we resize our calipers and move them on down, they do indeed appear to map out. This one's a slight bit early and this one's a slight bit late. But my point is that when you look at the relationship between the P's and the QRSs, you see this PR starts out long at maybe 300 milliseconds, but it gets much longer here. And then this P wave fails to conduct. And then what happens is your PR gets short again, it gets longer, and then this one fails to conduct. So what you have here is 3 to 2 Winky back or type 1 second degree AV block. Now what happens in type 2 second degree AV block is you don't get the PR prolongation. The P to P interval is still regular, and so if you map these P waves out, I won't bother with the calipers, but trust me, they're perfectly regular. And you have group beating here. You have a group of two, and then there's a pause on either side. But when you examine the PR intervals carefully, especially look at the PR segment, the PR interval doesn't change, and then this beat blocks. And the PR following the pause is about the same, and then you have a fixed PR here, and then you block again. So the PR never really changes. If we get out our trusty calipers and look at the R to R interval, you should be able to see that the R to R interval from here is exactly 2 times the previous R to R interval. So when the pause is exactly 2 times the previous R to R, that tells you that the PR is not changing, and that what you have here is type 2 second degree AV block. Now type 2 second degree AV block suggests that the block is below the AV node in the His bundle and the bundle branches. And sure enough, the QRS complex is a bit wide. It's more than 120 milliseconds in duration. So this is a patient who has significant disease below the AV node, and his conduction system is failing in a very characteristic way. Okay, well, second degree AV block is a big subject, so we're going to go on to the next section because we talked about type 1 and type 2. Now, high-grade AV block is unique, and it's defined as second-degree AV block, but worse than 3 to 2. In other words, 3 to 2 is the worst that you can get for type 1 or type 2. So that's not what this is. What you have is 2 to 1, 3 to 1, or anything higher than that. Here's an example. If you look at this ECG, you can see the QRSs look regular through the whole thing. Yes, indeed, they look fine, although they look kind of slow. The rate here is in the 40s. And when you look in front of each QRS complex, you do see that there's a P wave. But if you look very carefully, midway between these two P waves, there's another one. Okay, this is something that you can't miss. Those P waves here are not conducting. So you have this conducts and this blocks, this conducts, this blocks, and every other impulse is blocking. Now, you can see them actually very nicely here in lead V1. Now, a lot of people will immediately say, well, this is type 2. because it's 2 to 1. And they'd be wrong, because 2 to 1 is neither type 1 nor type 2. The reason is you really don't have two PR intervals in a row that you can tell whether the PR is getting longer or shorter. You only have isolated ones. In order to call type 1, you have to have two PR intervals in a row that you can tell that it's getting longer. Or in the case of type 2 second degree AV block, the PR interval doesn't change, and then you get a block beat. So it's either fixed or it's getting longer. Here, you don't have either of those situations because you only have single PR intervals to examine. So you cannot make the diagnosis of either type 1 or type 2. It is in its own category. That is high grade. Some people call it advanced AV block, or high grade is really my favorite expression. So high grade AV block is in its own category. And that's the way I wrote it, high grade. Okay? You can get very high grade periods of AV block. Okay, what you see is a sinus rhythm marching along. If you look at the PR interval, it is a bit long. It's about 280 milliseconds, but it's fixed. It doesn't really change. And then you have a P wave that fails to conduct, but it sets off a whole series of blocked P waves. So this is known as high-grade AV block. It's not really complete because you had conduction here, and then at the very end you have some more conduction. But you see this episode, otherwise known as a paroxysmal, so we call it paroxysmal high-grade AV block. It's a very specific diagnosis. You don't see it too often, but it is something that you should be able to recognize on an ECG. But the idea is anything of 2 to 1 or better, 3 to 1, 4 to 1, those kinds of situations are referred to as high grade and are neither type 1 nor type 2. I know that was a long lesson, but there is a lot of confusion when it comes to second degree AV block. In the last chapter of this section, I'm going to talk about complete AV block and how to distinguish it from other similar arrhythmias, so I'll see you in the next video. Meanwhile, this is Dr. Nick for the ECG Academy.